Good afternoon, good evening to you all. Okay, thank you for coming this late afternoon and joining us. This is our penultimate event for the semester. We have a last one that will be a research showcase. But let me first thank the audience here with us in person, but also those joining us on live stream and for making time to be with us and to welcome Dr. Rogo to give us a talk. Quickly, before I introduce him, I want to thank the Kellogg Center for International Studies for all the funding they give the specialty group and for supporting our events. The Kellogg Institute, thanks to the ECK Institute, faculty and staff, Joyce, Marian, Nidia, all the others who have worked very hard behind the scenes to help us pull this together. Thanks to my co-chair, Paul Ockebach, and a special thanks would go to the student planners, Deborah, Ade, Will, and then the last person on the team, that's Galeta. They put in so much work and we are thankful. For Deborah, this is special because it is also incidentally her dad who is speaking to us today. So I wanted to make sure I note that. So Dr. Bernard Nahlen would be the moderator. Apparently, him and a few people found themselves at the library because it's the Hesburgh Library. And this wouldn't be the first time that this is happening on campus. There are quite a number of Hesburgh labels. So we would wait for them, but we would proceed in the interest of time, and they will join us when they can. For those of you who don't know Bernard, he is the director of the ECK Institute, and himself an accomplished scholar, professional of global health, so really an appropriate person to moderate the conversation today. He has been a deputy coordinator for the US President's Malaria Initiative under USAID, has been a senior advisor for the Global Malaria Program, has been a director of CDC, Kenya Field Station, and a host of other credentials. So I'll quickly turn to our visiting speaker, Dr. Rogo, introduce him, and then I would hand over the podium to him. So first of all, I want to thank him for enduring a rather hectic travel with flight cancellations, but he's here and we are very thankful for the time he's able to share with us. His profile is too long to enumerate, so I would only provide a few highlights of what he has accomplished. Dr. Khama Rogo holds a PhD and a fellowship in gynecologic oncology from Sweden, at the time only the second ever in East Africa. He is a fellow of the European School of Oncology. He has authored over 150 peer-reviewed publications, chapters, books, presented at hundreds of conferences, and even given TED Talks. You can find him on YouTube on that. He has an equally long and impressive leadership record, was the president of the Kenya Medical Association and the Kenya Cancer Society. He was also the former chairman of the Kenya National Council for Population and Development and has had several roles globally with the World Bank as well as with the WHO. Has impacted many policies. I hear about 60 or so laws and policies related to health across Africa. So truly a big impact on policy. He founded the Nairobi Oncology Center, as well as co-founded the Africa Insitute for Health Transformation. Among the long list of awards that he has received, we should be proud to know that he received Kenya's very first Lifetime Achievement Award in healthcare. Ladies and gentlemen, audience, online and in person, would you please join me in welcoming Dr. Khama Rogo? Thank you.
Good afternoon. Good afternoon?
Good afternoon.
Or is it evening? And thank you very much for that elaborate introduction. Thank you, Notre Dame, for taking the risk of inviting me to come and have a chat with you. I have been challenged to share with you some points on, is it me? On the health in Africa. Thank you. Past, present, and future. This to me, as a African-born, bred, and trained physician, is a serious undertaking. But it's an undertaking that I do not approach from the poverty perspective, because my continent is rich, and my continent allocates a lot of money to the health sector. But that amount is not reflected in the health outcomes of my continent. For you, especially the African diaspora out here, you should be aware that the diaspora remittance in Africa for most countries is either 1/2 or 1/3 in terms of national income, dollar incomes. And of that amount, the biggest focus is in health. So you send a lot of money to look after sick relatives. Whether that money is used well or not, you'd still send it. Secondly, African sickness runs airlines and feeds private healthcare in other continents. The two busiest airlines in Africa, Kenya Airways and Ethiopian Airways, 1/4 of their passengers are sick Africans who are moving east-west, west-east between their country in Africa to either India, Turkey, Middle East, and so on, going for consultation. None of those consultations is done on borrowed money. They pay hard cash. 5 years ago, my group did a study on that money. And Nigerian alone, between Nigeria and India, in 2015, it was $1 billion US. Between the East African countries, Kenya, Uganda, Tanzania, and India, and this India alone was another $1 billion of people that we pay for to take aeroplanes and go abroad, to be told that you have grade 4 cancer and therefore incurable, and you are brought back. Those monies that I'm mentioning are bigger than the national annual health budgets of 80% of African countries. So that's money. When we look at this map here, Africans' health challenges are really at the heart of global health. But the voice of Africa is very distant. Just like in the UN Security Council, we have no voice. So is it in the health center. So we have the disease burden. But in terms of global health voices, it doesn't really exist. So if you put this stethoscope on the continent of Africa on that map, you'll hardly hear anything. Put it elsewhere, it is extremely loud. The problem with looking at Africa and health is that our government and most of the donor support looks at health in silos. And that silo of health is only one of the 17 SDGs. It is very, very clear from recent work that some of the other ADGs, when you tackle them, the reflection in terms of health outcome is a lot better and a lot faster than if you simply looked at health on its own. So look at each one of those other 16, and you will see the folly of looking at health on its own. The water has to be there, the environment has to be there, education has to be there. And it is that challenge where our usual interaction with the donor world fails, because donor support usually is to a sector, and even within the sector, to a very, very small part of that sector. So when you go to the Library of Congress and read the reports from USAID-supported programs, there is evidence of great progress and success. But when you go to the countries and to the regions and to the counties where those things happen, often you'll find it has been wiped off a year or so later. This is something that we must get. So here is the challenge that we must address. That can the people in health be aware that focusing on your area alone is inadequate? And can the other people also see their results as being reflected in the highly resistant improvement in the health sector in Africa? The big burden of disease we are all aware of. And I think you'll agree with me, those of you who've traveled in Africa, that that kind of luggage is not unusual. And that kind of luggage is basically this. We do measure the changes in the burden of disease in terms of DALYs, and many of you who are in this development thing will be aware of that. But the innovation that makes you turn this two-wheel motorcycle into being able to transport that load is what we all need and must do in Africa. The moving parts are few, but the goods to be moved are many. How do you do it? And that is a challenge. The regional burden of disease you are all aware of, and the red area that you see there in Africa is where we are focusing today. There are reasons, historical, why this burden of disease is the way it is and remains to be the way it is. The first is geography. The only continent in the world that is truly tropical is Africa. And the beauty of being in the tropics is that you have daylight for 12 hours and darkness for 12 hours. That the temperatures range within living range without you having to wear anything heavy. So for me, who comes from Lake Victoria there on the equator, I know that when the sun sets, it is night. When the sun rises, it is. And even our chicken and animal know it. So if there's an eclipse of the sun at 1 p.m. in the afternoon, our chickens come home to roost because they think it is night. But the beauty of this climate is also our undoing, because it's not only human beings who enjoy the life in there. There are insects, there's other animals, and so on. So we are then the center of everything you call tropical disease. If you moved that continent further north, then you would have only periodic summer. And periodic summer would mean that even the life cycles of mosquitoes will be interrupted. Not while we are over here. So without complaining about the geography, this is what it is. We do know that in Europe they used to have malaria, but because of seasonality and the winter, there's interruption of disease transmission. So historically, the past and present, this is our reality. I'm mentioning this aware that just before COVID, we had reached a point where the rest of the world were thinking that they were post-infectious diseases, that they were no longer worried about infectious diseases until COVID hit. And you know what happened in COVID. You can never be post-infectious disease, and you can never get rid of fully infectious disease because of that geography. So take it positively that if you are there, the level of vigilance for tropical and communicable diseases has to be very, very different from the people in Greenland. Second is a colonial legacy. The African health sector is a battlefield of civil and international wars. If you look at the red areas, those ones are traditionally Anglophone. And then the yellow areas, that is Francophone. Many people don't realize how different the Anglophone health system and the Francophone system has been. The European Union has been struggling to get these things together and not succeeded up to now. So the very fact that there's an Anglophone country and a Francophone country has made it impossible for Africa to speak the same language. Because if you went and you trained in the Anglophone system and you went to the Francophone system, they say, we don't do that here. The French don't do it here. It's not about the French. And that language thing, you look at the regulatory environment in the French system and the Anglophone system in health, is totally different. You look at the procurement system, it's totally different. So if you had the advantage of working across this, including the Lusophone, then you see the problems of bringing this together. And if bringing together has to be left in the hands of a weak coordinator like either AU, the African Union, or the WHO regional office in Brazzaville, then you are in trouble. So this legacy is a problem that we have not been able to solve. In fact, to this day, there is nothing that we can call the African health system. It's English, it's French, there's nothing that is truly African. So look at this as a challenge that people like me who are older than most of you have failed to sort out. This civil war that is between the colonial powers is also reflected in the manner in which modern health entered Africa. Modern health is less than 200 years old in Africa. In fact, to be more exact, it is less than 150 years old. Independence is only 70 years old in Africa. So look at that and start seeing what is there. That this colonialism came in, and the one thing that they never did is that they never recognized the traditional health systems. In fact, it went further and wanted to eradicate them completely. This is quite different from what happened in India, where you say their systems still remained, but not in Africa, because it was all tied to religion, to going to school and everything else. So the further away you move from the traditional healer, the more likely that you would rise up there. And it worked out so well that when the missionaries came and started the hospitals, and when the colonial governments were established, the first hospitals that were there were never really for the very sick African, but it was for the African civil servants. And you'll see that then in the progression in the development of social health insurance, like NHIF, it started for this civil servant that was taking over. So this history here and that civil war has not made it possible for us to take time and think of what is it that we must do differently. Because you will agree with me that the growth and rapid growth of health system must be a collaborative effort. It's not about eliminating one for the other to take over. It's about finding a way in which you can accommodate each other and work together. Yesterday, I gave a talk here on culture, society, and health. And that's what I was emphasizing, that until you recognize that even before modern health came, people had a system, you're missing something. And that fight then between the traditional healer and our modern health services continues. I was part of a group that tried to advance that into modernity in both South Africa and Ghana. And in South Africa, which was one of the few countries where we've managed now to put traditional health system into the health legal system, we had one problem. And that problem came out of a question after we had finished our document, that suppose you are an employer, Notre Dame University, and the country has accepted that traditional medicine is as good as and as recognized as modern medicine. And two of your employees come with a sick off, given 2 weeks off, and it is signed by a traditional medicine man. Would you accept it? Would you give it the same weight as the one that's given by the ND like me? And in what language is it supposed to write that thing? Those are practical things that are there because people have to live through that. So he will have to go to somebody like me to get that thing moving forward. So this past, we are still stuck on this. And therefore, we are still in the middle of this civil war. And we've got to move forward on that. Past two is fragility. 90% of African countries to this very day are still considered to be post-conflict and fragile. I deliberately put Nigeria there because I knew I would have some Nigerians here and they would say that they are not fragile. But I'm ready to convince them that they are very fragile. Yeah, and this fragility here, what it means in terms of continuity in improving system is devastating. So you go to DRC Congo, and what was it that you built 10 years ago that still exists? The civil war has destroyed it. You go to South Sudan, where 2006 we signed the peace agreement with General Powell there. And everything that we did has gone down. So this reversal, because of fragility, is a key area. And you cannot expect fragile and conflict or post-conflict states to develop with good indicators continuously. So you start seeing this up and down. For a donor, it is easy because your project is 2, 4, 3 years and you write your report on that. But in terms of the trajectory in health outcomes, it just doesn't work for us. And this is something that we've made a business out of, because the business of providing health in fragile states, emergency services, that's what has created the Medicine Sans Frontiers. There is a business on its own where you go in to take care of people as an emergency and then take off. That is not the way sustainable healthcare is built. So this past, which is still continuing right now, must be factored into our expectations in the health outcomes in my continent. But then presently, there's a population issue. Look at how quickly some countries can double their population. And in that doubling, you create very special vulnerable populations, the children under 15, and the ones who are neonates and so on. And then you also have the adolescent group that in the era of HIV became a big victim of everything. But not only that, that you create a high level of unsustainable dependency. So the population that can pay, for example, for social health insurance becomes a small part of that, not the rest of it. So social insurance suffers from inability to rely on a sizable part of the population that has earning capacity and can therefore support the others. So this population paradigm is important. And Africa is far away from attaining what population specialists call the demographic dividend, which the Asian tiger countries did achieve. That you have this young population that you take to good schools and you create in them innovators who create wealth. Ours are not taken to good school and are not given innovation, so they become a burden and they become cheap labor for social strife. And that is the problem that we have in that area. Now, let's look at the present. That with a little investment that we have made in public health, we have made some impact on communicable diseases without eliminating them. But with also the little improvement in social circumstances and incomes, we have expanded our production of non-communicable diseases. We live slightly longer now than it was 60 years ago, so the cancers are with us. We live less active life like the Maasais used to be, but still eat the same amount of meat as the Maasais used to, and we start having cardiovascular diseases. So the burden of disease issue is a major problem in Africa. We have not completed our journey on the infectious disease area, and we've opened a floodgate for non-communicable diseases. So that right now, people of my age have the same profile of people of my age here. And at a time when our health system is still struggling to manage communicable diseases. So there's absolutely no bandwidth for management of non-communicable diseases, whether it is the mental side, the renal side, the cardiovascular side, or the cancers. This becomes then a challenge that the present has for us to be able to deal with. Second thing on the present is that generally, globally, the health system is organized into primary care, secondary care, and tertiary care. And we know that the higher you go, the more expensive the unit cost of treatment is. But the only way of doing that is assuring people that if you go primary where it is cheap, but you need secondary, you can be referred. You need tertiary and can be referred. And the African health system, the referrals don't work. So even when we try to tell people to go to the nearest health clinic or community health workers, people know that you're wasting your time there. The primary clinic is underfunded, doesn't have medicine. So they vote with their feet and go to tertiary. So you find common cold being treated at Ibadan Teaching Hospital, at Kolebu in Ghana, at Kenyatta Hospital, because people do not trust that the system works. So it's not a question of just telling them go there. It's a question of demonstrating that by going there, you'll be seen faster. But should you require referral, then you'll be first online at the secondary level. But right now, you just walk there. They treat you like you've never been seen anywhere before. So this becomes a major, major factor for us to be able to deal with. Present too is a low and inequitable health expenditure. Many of you would have heard this common word in African health financing called the Abuja Declaration. 15% of African budget in every country should go to health. Our leaders promised this over 30 years ago. Two things have happened. Only two countries have ever managed it. And number two, even countries that want to approach it, the idea of a percentage doesn't make sense. Because 15% of Zimbabwean dollar 20 years ago was something. But when Zimbabwean dollar devalues 2,000%, then what is 15%? It just doesn't make sense at all. So the monies that we're putting in this sector are inadequate in the face of the double burden of disease and in the face of the population growth rate that we have already talked about, and we don't revise that. But even more significant is the management of that 15%. The budget system in our countries is an annual thing. In East Africa, it is every June because the financial year starts in July. Then during that year, you're given the budget that you're going to spend. By March the following year, you are beginning to work on the new budget year, and you've got to start returning the money that you didn't use. The African health ministries are notorious for returning the money. It's not because they have no use for it, but it's because although the budgetary year starts in June, your first tranche will come in sometime in October or November. So you have only, that's the first tranche. The financial year ends in next June. By March, you should start returning the money back to the treasury. So that disbursement is a major reality and a problem. So when the money comes, you use it quickly for things that you don't have time for, even doing the contracts and the procurement. And that is it. Go to every African country in September and they haven't received money for that financial year. Now, it may work for education, where the boarding schools, the headmaster may borrow the food from a vendor, but not in the health sector. You have salaries to pay, you have medicines to buy, and you have everything else maintaining that hospital, the theater, and everything. It is totally devastating. So if there was anything that we must do in this sector, we must release even that little money in time and on budget. It's not happening. So this then becomes an issue for us in terms of the inequitable and irregular disbursement of budget. It makes us remain where we are at the moment. The health workforce is an important one for us at the present. As we speak, there's at least 15 African countries whose presidents are visiting the rest of the development world to try and get jobs for their nurses and their doctors and their laboratory people. At a time when, because they've just started producing their more schools now, they can't employ them. The wage bill cannot be accommodated in our budgets. So even as we say that we don't have enough nurses and doctors, they don't have jobs. A graduate from the universities in Ghana or Nigeria today is not guaranteed of internship. and they sit for 2 years waiting for internship, by which time whatever you learned is gone. My own president, Ruto, has taken credit for going to Germany and Britain and arranging for nurses to be recruited to go and work there at a time when our own hospitals hardly have 1/3 of the nurses that they require. So this is a regional Pan-African problem that we have sorted out. It's not that we are not training them. Even when we train them, we cannot give them jobs. And why do you waste money doing that? Secondly, the variety of training and courses are not the priorities of the continent. They're the priorities of the training institutions. In Kenya, I can give you that the Ministry of Health recognizes 42 cadres. But the health institutions, the universities and others, middle level, train 120 cadres. So which means that there's 80 cadres that we train there that cannot be employed in the country. Their training is paid for by the nation. Does the Ministry of Health and Ministry of Education ever sit to work on their priorities? Absolutely none. Silos. So this becomes a problem that is not a question of production, it's a question of relevance and utilization. Sad it is when you see young medical and nursing graduates sleeping on the streets in front of the ministry headquarters in Dar es Salaam or in Nairobi looking for jobs. I've qualified, I have my certificate, please give me a job. And we can't give them jobs. That's a present problem. It's not numbers. It's a question of what you do with those numbers. You gave me very little time to talk about this, so I must jump quickly to the future. The future must be radical disruption. I've been a brave preacher of this. It cannot be business as usual. We have to define our own health system. We have to define how we're going to release the monies to the sector. We have to do everything. But at the bottom of it, number one is efficiencies. Our health systems right now work at 20% efficiency. With that little money that we are giving, only 20% of it is used properly. So inefficiency is big. Wastage is enormous. Two, accountability. That yes, we are using it badly, but where do you go to? Who do you complain to? Who do the community go to? Our parliaments are not answerable in this particular area. Three is local knowledge. Our research must be local. Using local knowledge for local solutions, we are not there yet. If you do something in the University of Nairobi, as we did during COVID, but there is another relevant or similar thing that has come from Johns Hopkins, the ministry will use the Johns Hopkins results, not the Nairobi University results. Because the Johns Hopkins results, when you use it, it comes with the money. It comes with the money to take you to workshops. It comes with the vehicles for you to drive around. So the incentives for using local knowledge is absolutely not there. I'm talking about innovation. We must use our local innovations, and there are many. I hope that during discussion, we'll talk about some of them. This sector is not a sector which you read in books and go and implement. It is you go in the field and work with the people to solve their own problems. And finally, there's data. Data. African health systems are not run on data. They run on political patronage. Data. What does data say? It was interesting during COVID. I'll share that with you and some of the things that we did, that local data. makes it possible for you to do what is called impossible. This is where the radicality ought to come in and appeal with you in an institution as this one here, that as you work with young Africans here and in our countries, that you emphasize on these 5 things, because this is where real change will take place. I will stop now because this is an area that is also present, and I have a lot to say about each one of these building blocks in terms of where we are in Africa now and what we must do differently. Thank you very much.
Dr. Rogo, thanks for that great presentation. And let's start with innovation, because you brought this up, because I think sometimes people look at African health systems, as you say, there's not just one, there's lots of different models from a deficit lens, as there's all these challenges, et cetera, et cetera. But I think you and others who are actually on the ground see that there's a lot of interesting things happening, and some of them very innovative that we in the United States might actually learn from. Could you say anything about what's going on, or some examples of innovative approaches that are happening now that might be scalable, or that we might all learn from?
Yes. The one that quickly comes to mind, and if you go to some of my TED Talks, I've talked a lot about that, is the use of the cell phone technology. Kenya has demonstrated to the world that through the M-Pesa, the movement of money, we are actually cashless. And that means that people can trust what's in the phone. It's an open invitation for the health sector to use that to leapfrog from our current lack of information and data to individual ownership of information and data. We have one simple one that we're working on in Kenya for antenatal care and pregnancy, where, because every Kenyan has 2 phones, the woman has her antenatal data on her phone, and the visits are worked out in a manner that she comes physically this visit and the next one is online. We've been able then to chart the journey of pregnancy for these women from the time they come in at 16 weeks to delivery, and be able to see a marked reduction in near deaths and maternal mortality. And I want to look at that because when we charted it, I do not know if I have that slide here. Let me just see. No, I may not have it. But if you look at the slide of the chart of a woman's journey through pregnancy to safe delivery, and you look at the 8-figure chart that the American astronauts used recently to go around the moon, it's exactly the same, that at every stage there is critical monitoring of the systems, whether it works or not. And if we can do it to people who are going around the moon, much, much cheaper, we can do it for a woman through pregnancy. And that journey then in the woman's phone, and that data then being available both at the facility and to the individual, is a kind of thing that we have to do. Africa is never too remote for the latest of technology. The second one was that during COVID, the rest of the world was surprised that we didn't die in the numbers that were predicted. And there've been a lot of argument on what it is. Okay, we were too young, so we are not very elderly. Our climate allows us to be outdoor and everything. But one thing that we never benefited from was vaccines. By the time the vaccines arrived, there is no single African country, sub-Saharan African country, that had a vaccination rate of more than 25%. None. But we reduced mortality. And there is lessons there on how that was used, working with schools, community groups, and so on. So there are things in the area of innovation that can be done, but it has to be done there. It doesn't have to be brought from outside for it to be there. And they can be local, they can be affordable, and they can be sustainable.
Thanks. Yeah, I remember discussing with you yesterday the example of COVID, where apparently there was an app that was developed for a mobile phone. If someone felt they needed oxygen, like where can you actually go? Where are the...
Yes, we did develop an app that would show people which is the facility where they went to, where there is an active intensive care unit, there's oxygen and so on, so that you don't travel all over the place looking for that. But you look at it and say, which is your nearest, and is a bed available there, and you'd be able to go there. Those things make a difference because in emergency care, time is of the essence.
So along those lines, I know that as we're all aware, the whole promise still to be seen of artificial intelligence. And even I know that the Gates Foundation is funding some work in Rwanda. I think there's interest in Kenya to try to improve some of the health system functioning and close some of the gaps potentially. I know you're involved in all sorts of exciting initiatives in Kenya and elsewhere. Do you have any thoughts on?
Yeah, AI is a game changer. It already is changing the game. The only problem we have is that we cannot predict where that change is taking us. So if you look at the areas that we need to leapfrog on, in terms of reducing the distance between the patient and the provider, in terms of increasing the frequency and the quality of that contact, and in terms of gathering that data so that it can be used for tomorrow's work, I think that AI is spot on. And the question then is, at what rate are we going to embrace this? Clearly, the ministries of health are not centers of innovation. So our centers of innovation must be both the private sector, the NGO world, and the university. My appeal then now is for research centers of schools of public health in Africa to be able to collaborate with other institutions to take leadership in this area. They are too silent, often too ready to absorb without being able to move to the next level.
Speaking of the private sector, just curious because we had some discussion about this also. I mean, frequently the public sector sees the private sector as competition. And some of that, frankly, is also driven by some of the international institutions like WHO and the kind of skepticism of the private sector. I'm just curious what your thoughts are. You mentioned how the Ministry of Health and others need to engage other sectors. So are there any examples you can give of the importance of engaging the private sector to plug some of these gaps?
I can make a very strong and bold statement. The future of health in Africa is public and private. Public can't do it alone. Those budgets that we are talking about, they are not going to get us anywhere. And the budget deficit is not going to be coming from donors. it has to come from private investment. But that one requires an approach that I led when I was at the World Bank, which is 3 stages. Number one, the level and quality of public-private engagement in this sector is extremely poor. This is one of the civil war areas that I was talking about earlier, that we are in civil war. The private sector looks at the public as inefficient and only taxes you. The public looks at the private sector as being exorbitant and only makes profit. Private sector investment, there's none. We like calling them private for profit. I've never heard of private for loss. So the entry of health in Africa was private sector. The faith-based is private sector. But they were relying on monies that were coming from out here. That model has given them problems now because their institutions have not been able to build a business plan that makes them work. And even their management was not given the kind of without. There was a Mother Superior in charge of my local Catholic. Mother Superior doesn't know how to run a hospital, but she's a very, very trustworthy person. So the business of running these things properly comes on board. Now, if you go visit any public hospital in Africa, I encourage you not to just stand at the entrance and admire the gate. It's usually beautiful. Go at the back and look for a place that I call the graveyard for equipment. And there you'll find a mountain of beds that are thrown there, X-ray machines that are thrown there, computers and so on. Some of them were donated and have not even been opened from their cases. The bed is only the wheel that you can do something on. That is a result of our very, very poor procurement system. Out here, your hospitals don't buy a CT scan. You lease and you guarantee service. At the end of that, you take it back and you get a new. In Africa, we still buy. And what we buy sometimes comes in and is not installed until 3 years later, or never installed at all. So the business of buying and having a minister or a president coming to open with a plaque there that it was opened by son excellence, this and that, but the thing has not worked. We should rapidly move into the modern procurement system of lease, because you pay for service, not for the hardware. This requires a robust private sector that can be able to work on leases and maintenance and everything. Secondly, for a long time, people never saw Africa as a producer of its own medicine until recently, COVID. There's absolutely no reason why we should be importing medicines that we can make in Ghana and create a market for local manufacturing. These ones are not going to be run by government. It is private sector to come in and do that. That will help us solve one thing. I think we discussed that yesterday, that the central medical stores, which has been a feature of African colonial health system, was created purposefully at a time when in the British system, medicine would be made in England. They would be taken to Southampton. A ship would take 3 months to Mombasa. So you needed a depot. And that is the beginning of the central medical stores. Now that we can manufacture there is no need for central medical stores. There's modern ways of the logistics of distribution of medicine. Right now, if I'm sending something to Nairobi by DHL, from Nairobi, they'll be able to read when the thing is at JKF, when it is in London, and when it is there. it is possible to use that distribution mechanism from the factory directly to the health facilities and monitor the quantities and everything else. It changes everything and the cost of medication too. Because right now, because of this very archaic system, paracetamol costs $1 in India. It's brought to DRC Congo and it is $56. What are you paying for? You're paying for the different people and hands through which this thing starts. It should come directly from the manufacturer to that. It guarantees quality, reduction of price. This is the kind of thinking that Africa needs at the moment.
You also obviously referred to the colonial period and what that's the kind of negative footprint it's left in many ways. And it's not new. There's a lot of talk about decolonizing health systems in Africa, not being as reliant on external funding. And frankly, over the past year, there's been a lot of disruptions in that previous system here in the US with the closing down of USAID. Even the Europeans, there's less external funding that's going to be available. Some people see that as an opportunity. Others are a bit skeptical. So I'm just curious what you think of what's going on now at this period. And again, when we talk about Africa, it's hard to talk about Africa because each country is different. But what do you think going forward is the likelihood that countries will be able to be independent, have their own finance systems, not be relying on external help? Just curious what your thoughts are on that.
I have no hesitation in seeing this as a big opportunity. And if I talk about USAID, the problem with USAID was the manner in which they left, not their leaving. I think that some of their programs skewed things to the point that there was dependency on that. The first group of people who suffered immediately the USAID money was withdrawn was not patients. It was businesses, gas stations that were putting money into these fuel guzzlers because USAID vehicles were never small ones. The hotels, because the proportion of donor money that goes into workshops and training and so on, they were running hotels. The airlines, the Air Force that comes from here to Africa and lands there and goes to those hotels. Those were the first people who suffered. The rest of it came in later. And had there been wisdom to make this thing more dragged out, I think it could have worked out well. I think that the opportunity that this leaves is, number one, what is the level of efficiency of the use of our budget? Right now, an African health budget only pays for salaries, nothing more, because all the other programs are done by donors. It will not surprise you that there's no African country, or very, very few, that are paying for their vaccines. There's very, very few that are paying for their family planning methods. If you are not doing contraception, family planning, and vaccines, what are you doing for your people? So it requires that we get back to the books and get it done. And this is where the collaboration with the private sector starts coming in. And in private sector, I'm not talking about the American side type of private sector. The private sector in Africa is that nurse midwife who uses her own family money to open a small clinic and maternity. They are there in their hundreds. But because of insecurity in the business and support for that, they don't grow. It's not the big hospital. No, it is that. And those are the people that we need in numbers because they're self-sustaining. They believe they put their money in there. They're not going to go away when war breaks out. And there is no support for this. When we worked with IFC, the IFC loans only go to big hospitals, not for SMEs in health. And his aim is small and medium businesses in health that are mainly funded from pocket that now need to be working with banks. And in some of the work we've done, we found that they are perfect payers back of any loan that they get. But the banks need to change to see health as a business and therefore one that you can put money on. So there's a lot of innovations around here that the exit of donors should not be something we cry about. We should look at it as an opportunity for us to be able to move forward. I believe that it is not reasonable to imagine that taxpayers in another country are going to pay for your mother to deliver safely, not for your child to get vaccination. If these things are truly important, we should. Because when it comes to buying arms, we don't get foreign aid. There's no USAID for arms. And the arms, the only wars we fight are our internal wars, not external wars. So I think that there is need for us to start looking at our priorities there.
Well, thanks. So before we open up the audio, and going back to priorities, I'm just curious if you could, like, what would be 3 priorities over the next 5 or 10 years you would highlight that people should concentrate on?
Efficiency and accountability. Whether it is Notre Dame doing a project in Africa or there is efficiency and accountability. I think we ought to make that our rallying cry. If you're really poor, then you want to be efficient. You cannot be poor at the same time flagrant. So efficiency and that. 2 is true investment in primary health care. Right now, if you look at the way we allocate our resources, the big hospitals take the big money. Primary health care is just talk. Working there, that is where universal health coverage fits in. And finally, for global health, the hubris of every 10, 15 years coming up with yet another declaration. In my lifetime earlier, I lived through health for all by the year 2000. The year 2000 came and there was no health in my village. Soon after that, we went into the MDGs. 2015 didn't come, we moved to SDGs. Same things. But health for all by the year 2000 was replaced by universal health care. If you know English, for all and universal mean the same thing. This, I think, we have to change the way we play around with the words to make people think that we're doing anything new.
Thanks. Why don't we open it up to questions? I think there's if you could speak into the microphone that's circulating here.
Can I quickly ask? Sorry, I have to run because we're in a departmental meeting now. Now, you gave us at the end, Dr. Rogo, that things you think we should be looking for in the future. I'm just wondering, you didn't mention remunerations for healthcare workers. I mean, a lot of the people I know, I come from Nigeria, a lot of them tell you that they can't even feed their families, staying in the situation. And as soon as they get out of there, by the way, the basic training of some of these doctors are so good, even better than many anywhere. So they go out anywhere and they shine. You know this better than I do, that in a lot of these countries, you are talking of governments finding jobs for other people, for their people. But a lot of these countries, Zambia has some of the best doctors in the UK, Kenya, Nigeria also. But the driving factor is pay, money, and so on. What do you think? What do you have to say about this?
Can you take a couple? Yeah. No.
Thank you very much for your presentation. At the beginning, you mentioned population growth and climate change. I was wondering if you could talk a little bit about what you think urbanization might do to healthcare in Africa.
Thank you. I've got a two-pronged question. So at the start of your presentation, you talked about how traditional medicines are not used, well, are not trusted. I think I wanted to get your thoughts on what you thought about, well, tying that into how we utilize data in Africa and even how we store data, if at all we do. Because it seems to me that in order for us to have confidence in traditional medicines, we need to have been able to track the effectiveness of our treatments. And that would depend on reliable data. But if we don't have this data, we wouldn't have that confidence in, we know it works. I mean, we know based off of my nuclear family that it works. But then that's where it ends. The nuclear family does not have a record that shows that this medicine works. But if you could extrapolate that out and have like a system of record keeping that stores this data, we could, to what extent do you think we can boost confidence in traditional medicines? That's the first thing. The second one had to do with the public-private partnership that you talked about. And something, for instance, in the supply chain. How or what do you think are the things that need to be put in place to make sure that the African health system, however vision we have or however we see it, does not fall into the trap of the American healthcare system where you have things working, but it's extremely expensive. And you can't access American healthcare if you don't have, there's even tiers to the health insurance. So you might be able to access healthcare, but then you're left with the huge burden of bills that you have to pay. So how do you marry the private healthcare or the private sector with the public? You're looking at?
Yeah. Let me start with Prof, because I know you're leaving. I've been in the forefront of the health association movement and so on. I've been on strike, I've been put in and all that. The primary issue is not how much money you're paid. When you finish medical school, you're so anxious to go and prove yourself that even if they only give you accommodation, and it's what happens, and you would go in there, money comes later, and your faith in the system is built then. When the system can't even give you free internship when you're not being paid, then it doesn't matter what they'll pay you 2 years later. 2, we have a problem in that some of the best paid people in Africa are not the most hardworking. members of parliament give themselves big salaries and so on. So that rationalization of who do you pay what is a failure across the board. I do not think that a consultant like me can ever be paid my value working with government. But we can make an arrangement, a public-private management, that allows me to give some of my time to private sector and so on. That is what keeps people there. So if you look across the African landscape, you look at states or areas which allows the doctor and the nurse to do something extra, you'll find that the power of retaining them is by providing that controlled and managed system, not the amount of money that we give them. Secondly, I've advocated that at a certain level of proficiency, the government should not be paying you permanent and pensionable. Permanent and pensionable should be for the lower cadres. A big consultant should be on contracts where you do so many hours and you're paid for those contracts. But you'll find that a consultant at my age is still on permanent and pensionable, and yet most of the money he's making is out there. So there's something that is very, very wrong in the way that we manage human resource in health. So the human resource management is a lot broader than that. I wish we had time and I would go through some of the incentives and disincentives that are in there. But it is not primarily the amount of money that is paid that is making them go away. It is the way the system treats them that makes them go away. With regard to the urban areas, Africa is urbanizing faster than everybody else. And unfortunately, urban poverty is now worse than rural poverty. And urban poor health, like the kiberas and slums and so on, is terrible. So in that population thing, I was not only looking at the ages and so on, but also where are they and the movement. And this movement into the cities looking for jobs and slums, as a health risk, it is major. And some of the biggest health risk areas right now are urban slums that require an address on their own. In the area of traditional medicine, I believe strongly in the strength of collaboration. Even before we start getting data, is a strong of collaboration. You see, health is about trust. And if you go into a new community, you've got to first of all ask, who do they trust? And work with that trusted person to be able to send your messages. This approach that we don't have data on you, so you go away, is what has created the war that we keep having. And it's a serious war, to the extent then that one of the biggest problems that Africa has is that we don't even know which ministry and which sector traditional medicine falls. You go to some countries, it's under culture and social services. You go to some countries, it's under sports. You go to some countries, it is under health. That shows you the amount of confusion that in there. What do we want to do with traditional health in Africa? It's a debate that I hope that your age group will be able to solve if mine doesn't. What was the last one? I think you had two. Yes, the private American health system, fortunately, and I thank God for that, cannot replicate it anywhere in the world. Even if you tried, it won't work. It won't work. So the fear that will be like America, let's put that one aside. The question that is in here is not how America got there, but how we can use the resources that we have both in the public and in the private. And that one can be done through organized engagement, policy, and regulation. For example, we do know that we don't want governments to run pharmaceutical companies, do you? So encourage private sector to come and invest in pharmaceuticals. You create jobs, you create expertise, and you bring drugs near. That's public-private partnership. Number two, did you know that for the first 30 years of independence in Africa, we've been independent for 70 years maximum, the government were the ones that were building new training institutions for nurses, doctors, and laboratory. Since then, the reverse is now taking place. The government is penniless. The ones they built, they can't run. So it's now private universities and institutions that are the big producers, and they're growing, and they're producing quality people at no extra cost to the government. All that the government has to do is to pay their fees like they pay in the public sector. So let's start looking at this and ask ourselves, what can we do with the range of resources that we can have? Number three, the biggest employer of skilled health services in most of our countries is not the public sector. It's the private sector. It's the mission hospitals. It is all those small clinics. Kill them and everybody moves out. But work with them to give immunization, to give the public health services that are in there. Discuss with them on how government paid for patients. You can mark how much you pay when it is a government patient. It can be done. It must be done. Three, you talked about the pharmaceutical and logistics. Outsource logistics. It works. Why must it be the government that builds the store, buys vehicles, and you know that they're totally inefficient? Outsource it. So let's look at a measured way of doing this thing rather than saying that, oh, this thing didn't work in America. They have their own problems. Let them sort it out. We have ours. The amount of money that the tax man puts on the table can't run it. And when they can't run it, then Nigeria goes and pays $1 billion to India. Suppose those hospitals were run by these high expert Nigerians who are here in Nigeria, that money would be in there. They would be going back to work in there. Create that environment that brings these people back home, because money is being spent going out there. I'm ready to have this debate with you if you'll buy me a beer.
Thank you very much for the wonderful presentation. I love the fact that you sold out about small enterprise, people along that opens maybe a pharmaceutical company in Africa with their own money. But at the same time, I want to learn your thoughts about, because that is kind of an avenue for substandard drugs to be sold. I'm from Nigeria, and I have, or back home, I know of small shops that sell different pharmaceuticals. But the problem is, how do we know that what they are selling is of good quality? And in as much as we are trying to help our health sector, but I mean, taking substandard drugs at the same time is going to cause more harm than good to us. Thank you.
Okay. The problem of fake drugs is a major one. 50% of the drugs we use in Africa are fake. but they're not manufactured in Africa. They come in through the briefcase thing and all that. Local manufacturing is part of the solution to that. The logistics that the government buys directly from the factory is also part of the solution to that, because you know who is producing it. There's been a lot of work, including the digital intervention that are in this area. And it is a confirmation of the weakness of our regulatory system. Our borders are porous. A lot of those pharmacies that sell fake drugs are not even licensed. So we have management issues around our pharmaceutical system and quality. It's a subject on its own in this area, but let me put it this way. I didn't have time to go through the 6 building blocks of WHO, in which case I would have dealt on this pharmaceutical area. From my standpoint, the 6 building blocks have created unnecessary complexity in the health sector. Before WHO came with the 6, in the early days when we were younger doctors, we had only 3. Those 3 M's: management, manpower, and money. You can't use the word manpower nowadays because of the gender issues. So that's why we went into HR. The management problems across the board in this sector are so pervasive that they allow the kind of things that you're talking about in pharmaceutical. We need to fix that. Without proper management, the health sector does not grow and it does not deliver. 2, the manpower, the human resource area. Nigeria, for example, has a very, very strict code in the pharmaceutical area that only a qualified pharmacist can open a shop. Not even a farm tech, it has to be qualified. And people have gone behind that so that this one pharmacist can have his license used by 10 businessmen. It's because that very colonial system has failed. Other countries have gone further to work out that the farm tech properly trained can open one. And there's all kinds of models that we can learn from in terms of making sure that whatever is sold in a country is not fake. But above everything else comes the issue of the penalties for being caught selling fake drugs. The figure in Naira is so small compared to the profit that you make selling fake drugs that you'd rather get caught than stop bringing in one. So there's a lot of things in this area that we need to get right, and it is not rocket science. It's simply stopping the civil war, focusing on how to move forward together. Public, private, different cadres within the health sector, the donor, the government, and so on. Without that, we are still going to be in this quagmire for much longer.
We can take one more question, 1 or 2.
Yep, 2 more.
I didn't see the hands up, so 2 more.
Okay, thank you for a great talk. So I have a question. So since the USAID exited in Africa, and we know that they were like a major stakeholder in funding healthcare, I definitely know that there's a huge gap, and I can imagine that there's been the impact can be felt already. So I wanted to ask, do you know whether the local governments are doing something about it? And can you say what maybe they've started doing to maybe promote the domestic resource mobilization to support healthcare?
Okay. Okay, thank you so much for your presentation. I found it very insightful. My question would be, as you were speaking, you mentioned something about how like private and public sector can come together and how we can move from this procurement way, like you buy machines, to like leasing. And I was thinking, I'm from Zimbabwe, and I was thinking in the context of Zimbabwe, where like the economy is failing, the currency is not even stable. There's lots of like brain drain, like people don't trust like banks, even like private companies are like struggling to operate on there. How would that like model practically work? Is there a place like in an African country where that actually works, and how does that look like? And how can Zimbabwe like work to be in that kind of like space? Thank you.
I'm glad you brought Zimbabwe on board. I did mention you earlier. You see, the expectation that the health sector would outperform governance in a country is false. When a country fails, all sectors fail. And there's this feeling that the country will go, everything else will fail, but the health sector will stand up because there's USAID, and so that is false. So my first appeal is that the health sector is a central part of governance. And it only works well when governance works. Everything else is medicine's frontiers. It's emergency medicine. And what Zimbabwe needs is not emergency medicine. Because I know Zimbabwe, I've visited many times and knew everything that's there. I know what you're capable of. So good governance cannot be replaced by anybody. And that's why I brought this, that conflict countries, that is a problem. To expect then that we will produce and help, it just won't work. Two, I think that came the questions from this side on the USAID. I believe that as a country, an independent country, you must work with a projection of a future. The donors come to play their part to support you to reach that goal, not to be with you forever. And things changed quite a bit because of HIV/AIDS pandemic. And because of that pandemic, there were lots of support that came in to strengthen the systems that were needed for that. They included, amongst others, the provision of antiretrovirals, the test kits, the blood screening, and so on. Those ones were fundamental. And USAID spent a lot of money on strengthening the blood screening process in Africa. Unfortunately, if you go back right now, 90% of them are not working. With the machinery and so on that were there, they're not working. So is the answer that we wait to call USAID again, or was it our responsibility to maintain what we had? That is a fundamental discussion that we must have. Two, what are the other sources of domestic funding? The first thing Is that efficiency? Whatever little we have, are we using it well? If the answer is no, then why do you want to add more money into this thing? If today we doubled the health budgets of some of these countries that are, I put out there with their weaknesses, will the health outcome improve? Absolutely not. So to be realistic here, let us start looking at our budget. If the budget to Kenya's healthcare, it's done, we are at peace and all, but that money is not released in June, it's released in October. Why do we expect USAID to be coming to keep things running for the 4 months? It's just common sense that we can do better than that because the money is actually allocated. 2, there has been, in terms of raising local resources, issues around sin tax, airline tax, and so on. And the idea is not that that money cannot be gotten. The thing is that if it is gotten, will it be used for health? Or will it go into other areas? And finally, the private sector. You see, when private sector works, the government gets more taxes. So my cry for private sector is not just for the sake of the health sector, but is also that you actually save 1 billion of Nigerian money that's going to India. 1 billion, my sister, is a hell of a lot of money. But right now, when they go to India, they don't go to public hospitals. Did you know that when you go to India, you don't go to public hospitals? They go to private hospitals. So when we are sending our guys to India, we don't talk about go to public, no. But when we say support private here, you say, will it be like the US? Got to get our heads straight on this matter. These young people, the entrepreneurial one, give them a chance to create those institutions that treat their own people. Right now, the public hospitals that I know across the continent are not places where you can even go and do research. Because you can't collect any data out of that. So let's get our acts together. The idea is not public to fight private. The idea is to say that the sum total of money that we have in the hands of government is that, can we be attractive enough for the private sector also to bring in? And then are there certain areas in health where there is advantages for the private sector to be in and certain areas where the public must come into? Primary healthcare, the public sector has to be there. But they don't have to be there across the whole range of that. We have countries that have opened cancer centers that work for only 6 months in a year. You started radiotherapy and it breaks down and nobody repairs it. Where else do you go to? Suppose we supported a PPP that maintains that machine and people have care throughout. Would that be a better option than just saying it is owned by government, even when it is not working? So the rationality of what we do in the health sector is a debate that I really, really encourage, that in your groups here, in the classes there, we start thinking beyond just the surface. It's much, much deeper than that. And it will take that deep thinking, bravery, for us to be able to get out of this quagmire. Because right now we are in a quagmire. Now, should USAID have left? Absolutely. Should they have left the way they did? No. Now that they've gone, what do? March forward, get your act together, we can do it. We really can, with just improving efficiency from 20% to 50%. That one alone. And that means that you don't pay this nurse who comes to work every day but has nothing to work with. Give her the wherewithal to dress the wound, to give the injection, because if she comes there sitting there doing nothing, she's not productive. These people that we train them locally. When they're students, let them go out there so that when they come out, they know exactly where they're going to work in. As somebody is saying there, we produce highly, highly competent young people. And in my time when we used to do all the specialization abroad, we were stars wherever we went to train because we were good. We can do it. But it has to come from this kind of discussion, and I hope we'll get there.
Thanks, Dr. Rogo, for this rich discussion, and I'm sure we'll want to continue this. So there's going to be a reception after this, and I encourage you to whatever remaining questions or thoughts you'd like to get. Dr. Rogo will be here with us for the reception. So thanks.